worked in the system for about 8. I'm one of your as-needed per diem staff nurses, and Michelle asked me to talk to you guys a little bit about PA catheters, or SWAN Ganz catheters, or invasive hemodynamic monitoring catheters. 3 ways to say the same thing, okay? So I have my little half person here, and I have our setup. So we are getting more and more SWANs into our unit, and that's how I call them, what I refer to them as, so you'll hear me say SWANs. We're getting more and more of them, and you guys are going to be seeing them on patients who have cardiogenic shock, patients who are in a severe sepsis state. We're even seeing them on our severe ARDS, ARDS patients. Now, whether that was COVID related or non-COVID related, we are seeing them on a lot of our patients. And the reason we're seeing them is because this wonderful little guy gives me information on hemodynamics. Hopefully you guys have all heard that term, hemodynamics, before. And what we're talking about with hemodynamics is preload, afterload, contractility, okay? So you guys can gather a whole bunch of information on those 3 things without this catheter. You do it every day with your assessments. What are my pedal pulses? What is my urine output? How do my lungs sound? What is their mentation? We do it all the time. But if I have this guy in, it gives me even more information, and I can get to a conclusion sooner. So stay tuned in the upcoming months, years, whenever. We're probably going to keep talking about hemodynamics and what all of these numbers mean to us as nurses. But for right now, all we're going to talk about is what this is and what it gives us and how to set it up, okay? So your patients are going to be getting these either in the cath lab, or they can put them in at the bedside. Our intensivists can, what we call, float them in, okay? So they can place them at the bedside. What you guys are always going to see is an introducer or a side port or a cordis. Again, 3 names for the same thing. So this little guy from here, it goes in maybe about 5 inches or so, and then it has this really big extension. This can be used just for fluid, just for meds, anything that you would put centrally. The reason we call it an introducer is because that goes into the vessel first. Then I can put my PA catheter through this little self-sealing hole at the back, okay? Almost always, you guys will see these placed in the IJ, right or left, right preferably, left as a secondary. We can place PA catheters femorally. It's rarer to have that happen, but it can work. But almost always you guys are going to see them in the IJ, okay? So in the cath lab or at the bedside, either way, you guys are going to have the patient. They should be, if they're not already sedated for the procedure, so that they're not moving around, okay? This catheter is long, super, super long. It has to be long because it goes all the way through my right atrium, my right ventricle, and out into my, you guessed it, pulmonary artery. So this little guy sits in my pulmonary artery. Now, at the end of this is a balloon. All of my balloons are busted, but I have a different catheter, and we'll get zoomed in, and that's what your balloon looks like, okay? You guys might have caught on, I said float the SWAN earlier. The reason we say that and use that terminology is we inflate this balloon, and it bobs around, okay? Bobs through my patient's right atrium, through their right ventricle, and out into their pulmonary artery, okay? But as you guys can imagine, when that's inflated in my pulmonary artery, what can't get past? Blood flow, okay? And think about circulation. What comes after my pulmonary arteries? Your lungs. So now when this balloon is up, I'm blocking blood flow to my lungs. Okay, now everybody's vessels are different sizes, so some of your patients might still get a little flow around, okay? Somebody with really super teeny tiny vessels won't get any blood flow. So this balloon being inflated for a long period of time, not a good thing, okay? But they use it to help get it in position, all right? Once your SWAN is in, whether it's at the bedside or coming from the cath lab, what I want you guys to remember is to double check your position and your locks. So on your catheter, you guys can see black tick marks. And from the tip, you have 1 black line, that's 10 centimeters. 20 is 2. 3, 30, 4, 40, and then when we get to 50, it's a bigger, thicker, blacker line, okay? It's not much blacker, sorry, it's just thicker. Then it's kind of like Roman numerals, a thick black and a thin black. Now I have 60, 70, 80, 90, and 2 thick black ones are 100, okay? We get really big involved into measuring things, right? We measure our ET tubes, we measure our OG tubes, we measure our central lines, or we should be. But the question always comes up, how do I measure my SWAN? What you guys are gonna take note of is the measurement at the insertion site, okay? So, if you guys can see there, I have a thick black and a thin black. That's 60 centimeters. So if I was documenting placement of this SWAN, I would say this SWAN is at 60 centimeters. I'm not gonna get a tape measure and measure what's on the outside of my patient. I'm using my hash marks, my tick marks, to measure what's inside, okay? So anytime you get that patient, they first come back from the cath lab, check that placement, all right? Provider just finished floating it at the bedside, check your placement, note it. If this moves out, it was supposed to be at 50 and you measure it and now it's at 40. It's no longer in my PA catheter. It's someplace else in my heart. Not life-threatening typically, but it's a pain in the neck. Maybe it's in my right ventricle, tickling my ventricle, causing PVCs. Maybe it's in my right atrium and I'm not able to get any numbers, okay? If it goes farther in, it was supposed to be at 60, now it's at 75. That catheter went farther into my pulmonary artery. That could be life-threatening. I could dissect my pulmonary artery. I could stop blood flow to my lungs for a long period of time. So this is one of those things that we need to know the measurement and we need to keep checking, because if it moves, that could spell problems for our patient. So double check the placement. Cath lab is working on a little handoff sheet. So if it's placed in the cath lab, they're gonna write down where it was when they left the cath lab, so that then when we receive the patient, we can double check and make sure that it's in the right spot. Now, how do we keep this from moving? Well, this lovely little protective sheath, which keeps this part of the catheter sterile, has locks on the end of it. So it gets locked here, up here at the cordis. There's a little tiny nubbin right there. And then this guy just goes over it and locks down. And then at the end, this is a twisty lock. So right now it can move. When I lock it, I can't move, okay? So once I check my position, the next thing I do, check this lock, because now you guys have all this extra stuff. If it gets tugged, it's not gonna pull. But if it's unlocked and it gets tugged, I can pull way out, okay? So position, lock, lock, check those locks, okay? If my catheter needs to be pulled back, can we as nurses pull this catheter back? Yes, we can. Our license covers us to pull the catheter back. We don't do it without a physician telling us what to do first. Pull it back 10 centimeters. The only exception to that rule would be if you have a DC PA catheter, DC SWAN order. Then we can go in and you just give a nice one slow straight pull, just like you were pulling a CVC, okay? You DC the SWAN and you leave the cordis or introducer in place, okay? There are little blue dead end caps that go over the end of this that we can place on there, and then you still have access, okay? So you're not gonna take both at once, you're just gonna take the SWAN. If they say, oh, we gotta advance this SWAN, go ahead and do that, Amanda. Do you guys think I should? Thumbs up, I should. Thumbs down, I shouldn't. Everybody should be going thumbs down. I, as a bedside nurse, as any nurse, cannot advance a PA catheter. It's against my license, okay? So your provider's gonna have to advance it. Our APPs can do it, our intensivists can do it, our cath lab docs can do it, but we as nurses are not permitted to advance that catheter, okay? So that's one big no-no, don't advance the catheter, okay? Now, that said, I've got a lot of stuff on this catheter, okay? I have a port that hooks up to a temperature probe. We have special cables in the ICU. They're called COCI cables, and you hook it up here. It's a different cable than our esophageal probe and Foley temp probe, but it will, once you hook it up, it will transduce a continuous temperature, a core temperature all the time. The monitor uses that temperature to calculate your cardiac output, cardiac index. So that's why it's hooked into that cable, okay? That's always the same, never gonna change. The other thing that we have is the red line, the red lumen, and that is our inflation balloon port, okay? So it's always gonna have a syringe. This syringe is special. it's a locked syringe. I can't pull more than 1.5 cc's of air. If you happen to lose this syringe, please, please, please don't just go to the med room and get another 3 cc syringe and put it on here. Someone will overinflate a balloon and we'll have problems, okay? So we're always gonna keep this syringe empty on here. This lock, when the line is broken, it's locked. When it's a straight line, it's open, okay? Now, remember I said this inflates my balloon. When does my balloon need to be inflated? On insertion, and then if my provider wants to get something called a wedge pressure, pulmonary capillary wedge pressure, I as a nurse can get a wedge pressure. I am permitted by my license to inflate that balloon. We only do it if there's a physician's order, okay? If you still don't feel comfortable doing it, it is perfectly fine for you to say, hey, charge nurse, can you do it? Hey, provider, can you do it? Hey, intensivist, can you do it? Okay, know that you're covered. We don't just wedge to wedge. We don't do it per protocol. We only do it if there's a physician's order, okay? And usually if they do order it, it's probably gonna be like every 4 hours, okay? So cath lab should send the patient to us with an empty syringe and a locked port, okay? If we float it at the bedside, take the air out of the syringe and make sure you're locked, okay? Those two are always gonna be the same. Now, we have 4 other colored ports here, 4 other colored lines. Gray and yellow are infusion ports. And the awesome thing is that you guys can...
Gray and white.
What did I say?
Gray and yellow.
Gray and yellow. See, I'm old. I have brain farts, guys. I'm actually just checking to see if you're awake in there, okay? Gray and white. They will tell you on the hub, infusion port, okay? RV and RA. You guys are smart, educated people. You know RA means right atrium, RV means right ventricle. So where these come out at the end of the SWAN is into those places. I can infuse any med I want to, any fluid I want to through these ports because it's onto the right side, the venous side of my heart, okay? If they come from the cath lab, they should have these capped off with our positive pressure caps like we have on our IVs, okay? Unless they need to use it to infuse meds, but more than likely they're just gonna be capped off. Keep one open for your push meds, for your ACLS code meds in case it needs it, okay? But I can infuse through these two, all right? Then I do have blue and yellow. And again, on the ports, it will tell me PA, distal, and proximal injectate, okay? Now, we were pretty smart somewhere along the way because we kept things color coordinated. Blue with a blue transducer to my monitor that gives me a blue CVP waveform. The blue port is in your right atrium and gives you an RA or a CVP pressure, okay? Your yellow port, PA, well, where is that, guys? PA, pulmonary artery. Do I inject anything into my pulmonary artery? No, we don't infuse Levophed, we don't infuse heparin, we don't put our propofol through my PA infusion, through my PA port, okay? No infusions. But that gets connected with my yellow transducer. That will show me a continuous yellow waveform on the monitor, okay? So what you guys are noticing here is all of these, this is in my patient, they hook up to lots and lots of spaghetti tubing, right? Oh, who wants to deal with this, okay? What it is it's a double transducer. 2 transducers with 1 pressure bag. We're accustomed to single pressure transducers for our A lines. Or you have a central line, you wanna hook up a CVP, we get a single transducer. The only difference is with a double transducer, I can transduce 2 waveforms with 1 bag. At some point in time, we may get a triple transducer. You might go somewhere else and see a quadruple transducer. Okay, it's just how many pressure monitoring waveforms you can get with 1 pressure bag. That's the only difference, okay? So cath lab's gonna hook this up if they come from the cath lab. If it's us doing it at the bedside, just trace yellow to yellow, blue to blue. What I want you guys to remember is at the end here, there's a little extension and a 3-way stopcock. Do not remove these. Cath lab is gonna leave them on for us, okay? And we need to keep them on, all right? Now, which port is left the way it should always be left? Place your bets, place your bets, place your bets. Bets over the yellow port. Why? Because it has a dead end cap. If I'm the one setting this up, I need to take my open-ended cap off and put my dead end cap on, okay? Always dead ended. So check that if it comes from the cath lab. They are gonna try and change all the caps for us, but we all know we get busy, so double check that those have dead end caps, because do we want an infection in my SWAN line? No infection into my pulmonary artery, please, okay? Now, why, Amanda, are we keeping these extra things on there? It's just more spaghetti. Well, I'm keeping this on here because if my provider ever wants to draw a mixed venous gas, I would draw it from here. And that would give me information about how my body's oxygenating, how my body's using the oxygen. There are times when we might need that information. That's where we can draw it from. More often used is the blue line 3-way stopcock, because this is where I hook up my syringe for cardiac outputs. So a separate thing that you guys are going to want to grab is my setup for cardiac output, cardiac index. This is stocked on our unit, and it's a syringe with one spike. You can get a 250, 500 liter, whatever we have of saline. No pressure bag needed. It's just, I call it, it's just my reservoir. It's just holding my fluid. Okay, open this up. Now this guy, you're gonna prime it, obviously, and squirt your friend next to you, wake them up, and then you're gonna take this syringe and take off that nice, lovely dead end cap that you just put on and hook it up there, okay? Now, in doing this, I've heard some of you guys say, you're hooking the syringe up here and switching this to this side. A long, long time ago in a land far away, textbooks said you had to inject your cardiac output and index in a straight line. I will tell you that that's true. The textbooks do say that. Textbook versus real life. This is already in line. I'm gonna hook it up here. It saves me a few seconds, and I've never had a problem getting accurate cardiac outputs and index by injecting it here. If you guys wanna disconnect and reconnect, that's perfectly fine, as long as you make sure it's clean and sterile and primed appropriately, okay? It's not gonna matter either way. So, to then get your cardiac output and index, you guys are gonna want to pull back. It's a one-way valve. So you guys can see I'm filling this syringe with fluid from here, similar to intra-abdominal pressure monitoring. If you haven't watched that yet, spoiler alert, it's coming, okay? And then you're gonna go to your monitor. And it's hard for me to go through all of it without a monitor here, but what you're gonna see up on your screen is start cardiac output, cardiac index, start COCI. And you're gonna flip your stopcock, and you're gonna hit start on that button, and it's gonna beep. So you have an auditory cue and a visual cue. And then you just slowly, and it makes this lovely squeaking sound. I don't know if you guys can hear it, but a nice, slow, steady push. And I actually did that probably a little slower than I needed to, but on your monitor, you're gonna see this nice spike up on a mountain, and then you're gonna it's gonna slowly come down, okay? And what the monitor is doing is it's measuring the time it takes for that fluid to get circulated, basically in a nutshell, okay? When we're doing cardiac outputs and cardiac indexes, we never do just one. So you guys are gonna wanna prime up again, pull back another 10 cc's, wait till it does its thing and it says beep, beep, beep. Okay, we're ready to go. And now start, and you do another one. We say 3. If you guys want to do 4, that's fine. If you're pressed for time and the first 2 you get are beautiful, then that's great. How do I know if I need to do more? Well, if your waveform is not pretty, if you have a flattened waveform, if you have like a long time and then it spikes up because somebody distracted you and they're like, hey Amanda, can you get a blood sugar for me? And it's counting, and you forget to inject, it'll throw your numbers off. So that's why we do an average, because you can say, that was a good one, that one was human error, that one the patient coughed 3 times while I was doing it. You can pick and choose, okay? This can stay connected. There's no reason to disconnect this. You guys are gonna probably be doing cardiac outputs and indexes at minimum every 4 hours. You may have a patient sick enough that we do it every 2 or even every 1, okay? That is your SWAN. That is what we add to it. That is what we transduce. Now these guys, again, we can have them on our transducer holder, or we can have them on the arm cuffs. I know it's nursing preference or whatever. Cath lab will usually come up with them right next to your patient. So you guys can do whatever is best for you and your patient, okay? If you guys have questions about how to level, how to zero, it's all the same as an A-line or a CVP. You're gonna get your level, and we're going phlebostatic axis. So this, not level, guys. I have it higher so you can see it, but I'm nowhere near level, okay? So my numbers aren't gonna be accurate. You guys are gonna get a continuous CVP. You're gonna get a continuous PA pressure, and that's a dichrotic notch waveform. It looks like an A-line, but it's not quite as high, okay? But it should have a nice little notch in it. If you guys wanna see what the waveforms look like, go to my friend and yours, Kathy White, Fast Facts for Critical Care. Under the hemodynamics section, there's a beautiful display of all the waveforms. And it shows you as they're advancing it, what the waveforms look like, okay? This right here is your PA waveform. That's what you should be seeing, okay? The other thing I like to highlight for you guys, and you can tell mine's been worn and tattered because I use it a lot. This is a normal guide of all the different numbers, all the different pressures, all the different things you guys can get, and it has all of your normal values. Some of you nurses have been nurses a long time, and you might be able to rattle off normals for an SVR or a PA diastolic. And some of you guys are just still new and learning, and so you're like, what? This is a great reference, okay? Step 1, know how to accurately get the information. How do I have it set up? How do I hook it up? How do I not make my patient bleed to death or get a massive infection? Step 2 to come is, what do I do with all my numbers, okay? So you will get CVPs, PA pressures, wedge pressures, SVR, systemic vascular resistance, cardiac output, cardiac index, blah, 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 all these alphabet letters. What to do with them right now? If you're brand new starting off, let your APP know, let your provider know. Let your buddy nurse know, let your charge nurse know, okay? We will change meds, change drips based off of those numbers. We might change other things. Maybe your patient's too cold. Maybe your patient's too hot. Maybe your patient needs fluid. Too much for me to go into right now, but use this as a reference to see, oh, my numbers are normal? Great. Or, oh man, my numbers are not normal. I don't know what that means, but I know it's not good. That's all anybody can ask from you. As long as you know what's not normal, then you can let somebody know, okay? If you have problems with your SWANs, ask the people around you, okay? But you guys may, in our current climate, turn to the left and turn to the right and find people who have just as much or less experience as you. There's nothing wrong with that. Knowing your resources is a big deal. I still need to ask questions to people, and I've been a nurse a long time. Your supervisors with this particular thing probably aren't gonna be a great resource because many of them don't have ICU experience, so many of them have not seen SWANs. If it's daytime, call the cath lab. They can come up, they can talk you through it. If it's the middle of the night, you can call me, and those of you guys that know me, feel free to call me, find my number, text me, okay? Actually, call me, don't text me. But CTICU up at Harrisburg is a great resource too. They're always there, and they get a ton of SWANs. Almost all their patients have SWANs. So where we'll see maybe, 2 in a month, 4 in a month, they see 50, 60 in a month, okay? So they're really, really comfortable with them. So they might be another great resource, all right? If you guys do have questions with anything, or I've messed something up, please feel free, text me, email me, daughterral@UPMC. Some of you guys know me, still have my card. Michelle knows how to get in touch with me, and I'll see you guys around. Thank you.